So with this, I think we'll go to our next speaker. Our next speaker is Dr. REEMA ma'am. Dr. REEMA is a professor at PGI and in vitreoretina and uveitis services. Ma'am has published extensively and received several awards from AIOS and other national and international societies. She's an active member of IUSG. And today, Dr. REEMA ma'am will be speaking about inflammations after anti. Over to you, ma'am.
Thank you, Anirudh. Is my screen seen?
Yes, ma'am. Your PowerPoint has not yet opened up.
Is it seen now?
I think you need to first unshare the screen and then share again. Yes. Perfect.
So, good morning, everyone. And I would like to thank the Chandigarh Ophthalmic Society for this invitation and Dr. Vishali for organizing this, making this program. So I'll be talking on the inflammation following anti-VEGF injections, an update. So one of the most feared complications of intravitreal injections, regardless of whatever drug we're using, is endophthalmitis, and which may be infectious or non-infectious. And this complication has been reported in eyes that have received all kinds of anti-VEGF injections for neovascular AMD. Now, if you can look at the rates of post-injection endophthalmitis, large prospective randomized clinical trials have reported the rates varying between 0.02 to 0.1%. And if we look at two meta-analyses, which included more than 3 lakh and 4 lakh injections, out of them, one study reported a significantly higher rate for bevacizumab, 0.058% versus ranibizumab, which was 0.029%. Now, coming to the rate of infectious endophthalmitis, they're definitely low, but maybe decreasing over time also. For example, the rate of clinically suspected infectious endophthalmitis after anti-VEGF agents at a single large referral institution in the reference given below, if you look at the rate between 2005 and 2017 data, this was 0.013%. And if you look at this subgroup between the same data of the last 3 to 4 years, between 2014 and 17, the rate was much less, that is 0.0038% as compared to 0.013%. However, there were no significant differences in the rates between the 3 agents that were used in the study. These were comparable to the data calculated by the IRIS Registry of American Academy of Ophthalmology, where they reported 0.025% rate of clinically suspected infectious endophthalmitis almost 2 years ago in July. And they did not find any significant differences in the rates of endophthalmitis between the 3 anti-VEGF injections. Coming to the non-infectious inflammation, the rate is not very well known, but this is also low. And again, this non-infectious inflammation also has been reported with all the 3 agents, but this is more common with Aflibercept. A prospective open-label non-randomized phase 4 clinical study of 100 eyes treated with Aflibercept or ranibizumab showed that the interior chamber reaction of at least 0.5 sun grading occurred in 19% of eyes receiving Aflibercept versus only 2% receiving ranibizumab. However, the vitreous reaction rate of the 2 agents was not different. Now, continuing with Aflibercept, additionally, 2 major clusters of non-infectious inflammation were reported. The first cluster was shortly after the drug got FDA approval in November 2011. And the second cluster was reported by the manufacturer themselves, by Regeneron, in February 2018. And they found that certain batches of syringes were associated with inflammation. According to a letter from the Vice President of Regulatory Affairs and Pharmacovigilance, Regeneron, the base rate of inflammation associated with Aflibercept averages approximately 1 to 4 cases per 10,000 injections, which is 0.025%. But during the more recent cluster, the rate increased to 8 to 12 cases per 10,000 injections among the vials packaged with the identified batches of syringes. So this was reported by the manufacturer as intraocular inflammation, and they did not distinguish between whether it was infectious or a non-infectious inflammation. Now, that is why it is important to distinguish between infectious endophthalmitis and non-infectious inflammation when we are giving these injections to the patient, because clinically it's very important because the management of the two entities is different. You need prompt and aggressive treatment in the form of vitreous sampling, whether it's a TAP or a vitrectomy, with intravitreal antibiotics in case of infectious endophthalmitis, whereas non-infectious inflammation would resolve spontaneously or with topical steroids and cycloplegics. So these are some of the points that we as clinicians use to differentiate between infectious and non-infectious inflammation. And the various parameters that we use are the kind of presentation of the symptoms, the pain, visual acuity, corneal edema, reaction in the anterior chamber, presence of fibrin or hypopyon, reaction in the vitreous, management, and of course, prognosis. Now, this is the chart that I've taken, which just shows the rates of sterile inflammation between various anti-VEGF agents, and I've marked the lowest and the highest rates. You can see it has been shown to vary between from 0 to 14.3%. Now, what is sterile endophthalmitis? This has also been referred to by some as pseudoendophthalmitis, which means any acute intraocular inflammation without infection that resolves without antibiotic treatment, unlike the true endophthalmitis. And several hypotheses pertaining to the etiology of sterile inflammation secondary to the intravitreal anti-VEGF injections have been laid. For example, when we look at intravitreal bevacizumab, what is the reason for the inflammatory response to intravitreal bevacizumab? And then we have diverse hypotheses. The intravenous bevacizumab is available as 100 milligrams per 4 ml or 400 milligrams per 16 ml. The intravitreal dose, which is 0.05 ml most commonly, it requires manipulation and risk of contamination. The bacterial endotoxins, which are frequent and recalcitrant contaminants of the antibody preparations during the production phase of the drug. Preparations of bevacizumab that are originally designed for intravenous use may contain traces of these bacterial endotoxins at levels that incite intravitreal inflammation, even though they are of no significance when this drug is given systemically. Another important fact is that the manufacturer of bevacizumab recommends to store it to keep it refrigerated at 2 to 8 degrees Celsius and to keep it protected from light. So any temperature fluctuation has been proposed as a factor that may increase the immunogenic properties of the drug as it does to the proteins. And we know that protein degradation creates novel antigenic epitopes which are not found in the parent molecule. Adverse events with bevacizumab have also been linked to the suspected contamination, possibly arising as a consequence of vial splitting and compounding. Now, this was the first study to directly compare the incidence of severe ocular inflammation following ranibizumab and Aflibercept treatment in routine clinical practice in the US. And this had the United States physician level claims data from the integrated data warehouse, where about 80% of the practicing ophthalmologists in the US submit claims data to this database. This compared the severe ocular inflammation rates per 1,000 injections over a period of 18 months for each therapy that was given for neovascular AMD. These are the number of injections. And what they found was there was significantly more severe inflammation in Aflibercept, which was 1.06 per 1,000 injections compared to ranibizumab, which was 0.64 per 1,000 injections during routine clinical practice in patients with neovascular AMD. Now, why Aflibercept mediates inflammation? The pro-inflammatory interaction of the Fc component, which is present in Aflibercept, it reacts with the intraretinal Fc receptors. This is a plausible pathophysiological pathway. And in primate studies of intravitreal Aflibercept and ranibizumab injections, Aflibercept was primarily taken up by the neuronal and the RPE cells, unlike the ranibizumab molecule, which is smaller and permeated the retina through intercellular spaces. The putative contribution of this Fc component of Aflibercept to intraretinal pro-inflammatory degeneration has been supported by recent observations of increased expression of FC receptors in the retinas of donor eyes from patients with neovascular AMD compared to the healthy controls. As with Aflibercept, this FC component is also present in bevacizumab. So this provides a further test of the hypothesis that the inflammatory response is mediated by the FC fragment, which is present in these molecules, which interacts with the retinal FC receptors. And high rates of culture-negative endophthalmitis following bevacizumab compared to ranibizumab are also compatible with this hypothesis. So the prophylaxis, currently the only preventive prophylaxis which is known is for post-operative infection is the application of topical povidone iodine. Evidence of efficacy of topical antibiotics is inconclusive. This retrospective cohort study of the US claims data examine the risk of developing endophthalmitis following the intravitreal injections. All the three agents were compared in patients with neovascular AMD between 2011 and 2013. And the primary outcome was occurrence of endophthalmitis within 30 days of the claim for the intravitreal injection. And out of more than 8 lakh injections from 1 lakh patients with neovascular AMD, endophthalmitis rates were 0.1% with Aflibercept, decreasing with bevacizumab, which was 0.56%, further decreasing with ranibizumab, 0.047%. Now this shows that Aflibercept, which is the first bar, had significantly higher endophthalmitis risk compared to ranibizumab, and the endophthalmitis risk was similar for both bevacizumab and ranibizumab. This shows the rates of endophthalmitis during the 6-month splitting period for the 18-month study. And as you can see, Aflibercept is topping everywhere in terms of rates of endophthalmitis as compared to the other two drugs. So this was the median time from the date of injection to the first episode of endophthalmitis, which was 3 days in case of Aflibercept and 5 days for bevacizumab and ranibizumab. Coming to the endophthalmitis aspect of the CATT trial, the incidence and outcomes of endophthalmitis were also studied in patients who were enrolled in the CATT, and endophthalmitis was reported in 11 of 18,000 injections from 11 patients. And they found that the rate of endophthalmitis was 0.15% among injections with no antibiotic use, 0.08% among injections with pre-injection antibiotics only, decreasing 0.06 among injections with post-injection antibiotics only, and further decreasing to 0.04% among injections with both pre- and post-injection antibiotics. All these patients received intravitreal antibiotics and 4 underwent vitrectomy. So they found that the rates of endophthalmitis were low and similar to those in other large-scale studies. So use of topical antibiotics either before or after the injection does not seem to reduce the risk significantly. Now, with the upcoming Brolucizumab, we have information on inflammation related to this drug. The incidence of intraocular inflammation in Hawk and Harrier was higher with Brolucizumab at 6 milligrams, which was 4% compared to 2 milligrams of Aflibercept, which was 1% in eyes that were treated for neovascular AMD. So here we had a spectrum of uncommon findings as compared to the previous agents in terms of retinal vasculitis and retinal vascular occlusions in these patients who received the drug. So there is, keeping in view for these kind of uncommon intraocular inflammation findings, there is a need for early diagnosis, prompt and timely intervention, intensive treatment, intensive observation of these patients, and frequent monitoring to minimize the risk of progression of these events. I'll not be covering this in detail because we have Aditya speaking on Hawk and Harrier real-world experience. So this is the recent most publication on the expert opinion on management of these inflammation-related complications with Brolucizumab. So coming to the Indian perspective, we had a high alert in India following a single incident of cluster endophthalmitis in eye hospital in Gujarat. Why I'm talking about is because we have a high volume of patients in India. We have a high volume usage of these drugs. So it's important to know what happened related to the inflammation of all these drugs. So in January 2016, the DCGI issued a high alert notice on the use of bevacizumab. This decision not only caused consternation among Indian ophthalmologists, but also led to a virtual ban on the drug for intraocular use. Multiple studies have shown the efficacy, the safety, and non-inferiority of the relatively inexpensive bevacizumab to the other two agents. So deliberations with the concerned authorities resulted in withdrawal of this alert in March 2016. So we had subsequent to this, we had the guidelines for intravitreal injections by the VRSI and the AIOS. And these were drafted jointly by the AIOS and VRSI along with 4-member expert committee based on a meeting that was held in February 16 between the joint DCGI, various representatives from AIOS, VRSI, and from Roche. And the guidelines say that ophthalmologists in India can use Avastin as an off-label drug for intravitreal injection. However, you need to have a proper informed consent from the patient. The injection should be performed in sterile environment, should be done by the trained ophthalmologists. And just a little bit about our experience. In July 2016, we had 28 patients who developed cluster endophthalmitis after receiving intravitreal bevacizumab, out of which 6 were treated with neovascular AMD, and 12 had TAS-like reaction, and 16 had classical endophthalmitis. And these were the various clinical symptoms that the patients presented with. All of them had blurred vision. And we found the organisms Stenotrophomonas maltophilia in all samples by the MALDI and by bacterial cultures in 10 patients. So the suspected injection vials and syringes were the ones which grew this organism, and the source of the outbreak was confirmed to be the contaminated bevacizumab vial. So the most critical aspect of this is that the process of compounding, which may compromise its sterility. With no compounding pharmacies available in India for the preparation of this drug for the use by the ophthalmologist, we have the guidelines by, as I said, to minimize such events in the absence of compounding pharmacies. Another concern is immediate sequential bilateral intravitreal treatment with anti-VEGF injection. As per the AIOS guidelines, it is recommended to do the injection procedure in an OR or a sterile room designated for such procedures, taking all the precautions as are taken for any intraocular surgeries. We do not recommend intravitreal injection in an office setting. Bilateral injections are not recommended, and injection for the other eye should be planned at least 1 week later. So in an Indian scenario, the risk of bilateral endophthalmitis following the immediate sequential bilateral intravitreal injection, though small, we cannot ignore it, given the fact that many patients receiving these injections already have very good visual acuity before the injection. So it may invite medical legal problems for the practicing ophthalmologists too. So the AIOS, the recently published AIOS survey on the practice pattern of anti-VEGF injection, which was an online survey to evaluate the practice pattern of Indian retina specialists in administering the intravitreal anti-VEGF injection. The various categorizations were pre-injection patient preparation, injection aliquoting, injection administration, post-injection care, results, and the results were then compared with the similar surveys in the Europe, UK, and the US. 73% retina specialists responded in this, and these were the various figures that they found. So the conclusion of this survey was peri-procedure antibiotic use, injection in the minor OR, wearing of gloves and masks were higher than practices in other countries. Ophthalmologists in India practice sepsis in intravitreal injection procedure, but there is no uniform protocol for aliquoting bevacizumab. Single-use bevacizumab vial for exclusive ophthalmic use would further improve the safety of the procedure. So thank you very much for this, giving me this talk. Thank you.
Thank you, ma'am. That was a very exhaustive and very learned presentation. I think it hardly leaves any scope for questions.